Thank you very much for the kind introduction. So we have moved on to the next spectrum, which is the management of advanced stage of Parkinson's disease. And I'll try to focus my talk on cases and also things that happen in Southeast Asia. So you have seen this in the previous speaker's slide. And this is the timeline of Parkinson's disease, where they start with premotor symptoms, mainly non-motor, things like REM behavior disorder, depression, hyposmia. And then they go into the motor symptoms, which are the bradykinesia, rigidity, tremor, and postural instability. And they have this gap of what we call as a honeymoon period, within normally about 3 years to 5 years. If you give them medications for Parkinson's, whether it's MOIB inhibitors, dopamine agonists, levodopa, they find that the medications are very effective. But as time goes by, maybe after 5 years, about 50% of them will start developing problems. And then we go into the mid-stage and late stage of Parkinson's disease, where you have also motor and non-motor features. So you go into things like motor fluctuations, dyskinesias, falls, difficulty in swallowing or dysphagia, non-motor symptoms like dementia and psychotic symptoms. And these are actually very challenging to treat. This is one of the chapters that we did together with Dr. Thien, and also, of course, the brain from this is actually Dr. Bidaya Siri on the challenges of Parkinson's disease care in Southeast Asia. And as you can see that the vital to successful management is the availability of skilled personnel. And we're talking about neurologists to diagnose, manage, and deliver care. But as you can see, there are actually not many neurologists as compared to the population of people with Parkinson's disease. And in Malaysia, probably we have about 102, maybe until now about 130 neurologists. And we are actually treating, estimated from the global Parkinson's disease collaborators, about 19586 numbers. So it's a huge number. So we still have a lot of challenges. So subsequently for my talk, I'll actually have 5 cases, and we try to see how we can deal with these 5 patients with advanced Parkinson's disease. So this is my first patient, a 66 years old patient with Parkinson's disease for 9 years. She's on Stalevo, which is actually levodopa, carbidopa, and entacapone, COMT inhibitor, at the 150 milligram dosage 4 times a day. But she also takes Ayurvedic medications, and I'm sure that a lot of us here, especially in Southeast Asia, where patients go to traditional medications before they come to us, or actually they take them concurrently. And this patient is on 2 medications called Kapikachu and Ashwagandha. Problem is that after 3 hours, she develops anxiety and feeling something bad about to happen. And now we know that these are actually wearing off effects, the non-motor wearing off effects. But at 1 hour, she develops these severe abnormal movements after each dose of the Stalevo, and this is what happens. So if you see this patient, she has dyskinetic movements involving generalized upper limbs, lower limbs, and also ocular. These movements, the eye moves looking right and left, is unintentional and involuntary. Also, the neck, the cervical region is also dyskinetic. And the sound.
June, May, April, March, February, January.
So I try to distract her, and the movements become even more. Okay. So this happens normally at the peak dose of the levodopa, the medication, and after that she'll go off at about 3 hours, so they become very bradykinetic. The tremors come in and the stiffness comes in. So this is back to the literature quite a number of years ago by Roach, Bidaya Siri, and Helen Ling in 2009, but the principles remain the same. We review the patient's drug regime to determine the drugs that may alleviate dyskinesia, but without reducing the off symptoms, because now you have dyskinesia, peak dose dyskinesia, plus you have an off symptom. So we try to take off drugs such as sertraline, MAO-B inhibitor, which actually have very mild effect, and we try to remove anticholinergics, which is normally just useful in the young people for tremors. And then we later on, if it's still a problem for the dyskinesia is still a problem, then we examine other adjunctive therapies. We try to take off sustained release type of levodopa. We might take off or reduce COMT inhibitor, the entacapone in this case. We may reduce the levodopa dose, but at the setback, when you reduce levodopa dose, the off time may increase. So you may want to either increase the frequency or add in a dopamine agonist. Lastly, clozapine, but of course, always the concern of monitoring of the white cell because of agranulocytosis in the minority of patients. If you look at the International Parkinson's Disease and Movement Disorder Society evidence-based medicine review, the ones that is efficacious for motor fluctuations, which is the wearing off effect, is dopamine agonists, the newer generations, apomorphine, MAOB inhibitors, COMT inhibitors, zonisamide, which is quite new for Parkinson's, but I mean, it has been in the market for epilepsy, levodopa, carbidopa, intestinal gel, and of course, deep brain stimulation, whether it's STN or GPI. The efficacious one for dyskinesia, we have amantadine, clozapine, LCIG, and also DBS.
Hitung dari bulan Disember ke January patah balik.
Sorry, okay. So what I did for this patient was that I took off the Stalevo so that I can get rid of the COMT inhibitor. I reduced the levodopa benzerazide. I changed it to Madopa, which is levodopa benzerazide without the COMT inhibitor, to half tablet, but I increased the frequency up to 6 times. Yes, a little bit more inconvenient, but it does the work of reducing the peak dose dyskinesia. And I add in amantadine, as you can see from the previous slide, that amantadine has good anti-dyskinetic effect. What about the Ayurvedic medications? Well, initially that they feel that the Ayurvedic medications are the ones that help the patient and not the medications that we have given. So it was quite some time before I got to convince the patient. And after the next round, they actually took off the Ayurvedic medications because I felt that it was very difficult to adjust because I do not know what I was adjusting. And then I advised for bilateral STN DBS, and they are actually thinking about it. And this is the paper for, looking at the challenges of Parkinson's disease care in Southeast Asia. And we find that from this case, there are a few issues here. Number one is the knowledge gaps of Parkinson's disease in Southeast Asia, and including the socioeconomic situations, availability, and misperceptions. There are still misperceptions that PD is caused by non-medical causes such as witchcraft, cold weather, and so on. And this actually lead to patients seeking for traditional healers. So if we look back at this patient, and we look back at the medication, and one of the medication is actually Kapikachu. And if you look at the literature of Kapikachu is actually Mucuna pruriens. And this is like a legume that you see on the first picture, and the roasting seeds below. And if you, in fact, what is Mucuna pruriens? The content is actually levodopa, found about 4 to 6%. So patient is actually on another form of levodopa. And these two articles are very interesting reading, that it tells us that when the patient has these motor fluctuations, the ups and downs, the on and off, it's not only the motor symptoms, it's not only when they become off, it's not only the akinesia, rigidity, and tremor, but it also affects the thinking and the mood and emotion. So they get apathetic when they are off, they get withdrawn, they get sad, they get depressed, they become slow in their thinking. So they are actually, the off period always asks about the non-motor symptoms and whether the non-motor symptoms fluctuate when they are off, or is it the whole day. I just would like to introduce 3 relatively new drugs, perhaps in Asia or Southeast Asia, which is used for motor fluctuations and dyskinesia. The first is safinamide, which is a MAOB inhibitor, and also a channelopathy. And this is a very new trial which actually came out last month. The post-hoc analysis of the SETTLE study in the Journal of Movement Disorders in 2023 by Ron Roach and his team for the SETTLE study. And it shows that it increased on time. And the interesting thing about the study I read was that the motor functions, which is the UPDRS-3 score, actually improved in Asian but not in Caucasians. And it did not worsen dyskinesias, and none of the Asians actually experienced adverse effects. The second one is opicapone. It's a COMT inhibitor which increases on time, but the good thing, I think, it's a daily dose. Zonisamide, as most of us probably have used it in epilepsy. It's also a MAO-B inhibitor plus a channel blocker. It reduces off time, and also it reduces the disability of dyskinesia, although there was no difference in the duration of the dyskinesia itself. If all that fails, normally we go into three modalities. First, the brain stimulation. Second, apomorphine infusion. And third, levodopa-carbidopa intestinal gel, LCIG. And there's always comparisons between these three. But if you look at availability in our region, perhaps DBS is nowadays more often used. Apomorphine is available in quite a number of countries now in Southeast Asia. But LCIG, we don't use it because of the cost in Malaysia, but I think Thailand is the only one who's using LCIG. All right, so that's about the motor fluctuations, dyskinesias in advanced Parkinson's disease. Case number 2. So this is a CCTV video which was brought to me by my colleague, Dr. Tanai Hui from UMMC, and you can see this lady with Parkinson's. So after prolonged standing, he was at the door, 2 maids were washing the plates, and a drop attack. So this is actually very, very dangerous and could lead to not only morbidity, but actually mortality, death. So what happens was that she developed orthostatic hypotension. The blood pressure drops after prolonged standing, and she had a syncopal fainting episode. So you could get falls, you could get subdural hematoma, bleeding in the brain, and prolonged, you may actually develop cognitive impairment. But we're always concerned that what if the blood pressure is high when they are supine because of autonomic dysfunction? Will they get stroke? Will they get myocardial infarction? And this study, you can read, there's 3 types of patient, the A, B, and the C. Of course, the worrying one is the C. When actually supine, the blood pressure is normal. As they sit up, the blood pressure becomes lower, but still part of it within the normal low range. But as they stand up, the blood pressure drops. And these are the cases that we need to pick up. What's the management of orthostatic hypotension patients? The non-pharmacological approach would be to correct the non-neurogenic causes, lifestyle measures, crossing the legs, prop up the bed, reduce the postprandial hypotension, avoid too hot weather, sweating too much, drinking more water, more salt, abdominal binders, and so on. It's easy said, but may not be as easy for the patients to actually do all this. And I find things like abdominal binders, stockings, they will actually wear once, twice, and then they won't actually do it. Salt and water depends a lot on their caregivers because their motivation may not be so high. And we look at the pharmacological treatment, we have to identify blood pressure medications, sildenafil, alpha agonist, remove all those which are not so necessary ones. And then we have to identify the PD medications, perhaps because majority of them do also cause orthostatic hypotension. We may want to remove the MAO-IB inhibitor, dopamine agonist, and may perhaps just leave levodopa because it's the most efficacious one. 3 drugs which has some evidence in orthostatic hypertension in Parkinson's disease: midodrine, fludrocortisone, and droxidopa. So in my practice, I use fludrocortisone and midodrine. We do not have droxidopa because it's still relatively new. The rest are actually case reports. The challenges we have for treating orthostatic hypotension in Southeast Asia, the availability of medications. I remember just maybe about maybe 10 years ago, I used to ask patients to go to Singapore to get midodrine because we do not have midodrine in Malaysia. So that was how difficult it is. Rural community far away from the central, neurologists are not there, and perhaps they're not aware of this problem of orthostatic hypotension. When they come to the clinic in the rural areas, they always measure the sitting blood pressure or the lying blood pressure because they always see the doctor sitting down, and that may not give a true reflection of the low blood pressure when standing up. Caregivers, the hot weather in Southeast Asia, which actually precipitate the problem, and also lack of the knowledge. All right, move on to the third case. So this is an interesting, one of these days I got a letter from the patient's daughter who says, "Dear Dr. Lim, please help me. We are desperate and need a solution. We go through this shouting practically every day and aggressive behavior every other day. And the first video, he actually picked up a metal paper weight and threw it down the stairs. And he has a review with you today, and not even sure we can actually get him to the hospital. His Montreal Cognitive Assessment was 12 when I examined him. So you see this typical tremor in this patient, resting tremor. He's Parkinsonian, but he has an extra feature now, which is actually dementia and psychosis. So he would mess up the place. Of course, we are happy that the patient can still walk, he can still function, but at the same time, the psychosis is not only dangerous for the patient, but it is also dangerous for the people around the patient. That is actually a heavy door stopper. So if you are climbing up the stairs and it does this, then that will be a problem. So I tried to look into psychosis and Parkinson's disease in Southeast Asia, and this is a paper from Singapore which shows that there's about 18.8% of PD patients associated with psychosis. And we know that normally the psychosis, in psychosis, they have hallucinations which are normally visual. Rarely they will be auditory, and they have delusions such as paranoid or beliefs of infidelity and abandonment. We also need to look for if there's a sudden decline in their psychotic features or their cognitive features. Look at things that may precipitate it, such as dehydration, infection, metabolic problems, psychological factors, and also medications that has been recently introduced. So we assess that medical problem, we reduce or eliminate any non-PD psychoactive medications, especially anticholinergics. And there is a method of reducing or eliminating the PD medications. First, anticholinergics, get rid of that. Second would be amantadine. Third would be dopamine agonist. Fourth would be MAO-B inhibitor. And then last would be COMT inhibitor. We normally leave levodopa because the patients need it for their motor symptoms. If the psychotic symptoms are tolerable for 4 weeks, because pimavanserin, which is an inverse agonist, works slower, we can introduce that, but that again is not available in majority of our countries. If not, then another favorite drug of mine, quetiapine. Of course, clozapine has its advantage, but just we have to do the monitoring. So the challenges in Southeast Asia, the availability and the cost of the medication. We don't have pimavanserin, quetiapine may not be that cheap for patients. The availability of nursing home and institutions. If you have a patient like that in the nursing home, it will disturb all the caregivers and all the other patients. And majority of the nursing homes would not want to take this type of patients, and that becomes a problem because the family cannot take care, neither can the nursing home take care. The cost of caregivers and institutions is also very high, and the higher rate of hospitalization and institution itself. There are certain treatment by non-neurologists or non-movement disorder specialists who still use dopamine antagonists and first-generation antipsychotics, which would worsen PD. And also the lack of close family members, except, example, the rich ones in my country, they send their children all abroad and they leave themselves at home. So that would be an issue as well. Okay. The fourth case is a 75-year-old man with Parkinson's disease who recently noticed difficulty in walking and having frequent falls. What would be the approach to treat this patient? So I think from this snippet here, you already know that this patient has Parkinson's disease plus freezing of gait. So what is the next question you want to ask yourself if the patient has freezing of gait? Okay, so this is overcome by certain visual cues, and you also want to know whether the freezing of gait is only during the off time or it occurs both during the off time and on time. And this is the algorithm. Of course, the non-pharmacological things like sensory cues, assistive devices, and change in the walking pattern, you teach the patient how to walk, all helps. But if it's at the off state, the freezing of gait, then we treat like what the patient has during wearing off. We increase the medications, we add on other medications like COMT inhibitor, dopamine agonist, MAOB inhibitor, or we increase the frequency and the dose of the levodopa. And lastly, of course, DBS will work for this type of cases. But if it is freezing of gait in the on stage, then we probably need all those assistive devices, and we normally do not recommend DBS in those cases. So I have 3 clips here. First is my patient. I just show you that they actually have difficulty when they go through a narrow pathway, and they can suddenly freeze and fall. So falls is one of the dangerous complication of freezing of gait. So as he goes through the door, then there is a visual cue, those lines on the door. And I've got patients who draw lines all over the floor, or they follow the tiles of the floor, which is actually helpful, and it reduces falls in them. So you can see. And this is the second one. The first one is visual cue. He follows the round dots. This is one of my Parkinson's patients. I went for lunch with him because he's one of the president of the society. And then now he said, wait, let me think first, and then let me play the auditory cue on myself. So his own internal auditory cue, 1, 2, 1, 2, and he walks well. And of course, when he reaches the staircase, as he climbs up the staircase, there's already a cue for him, and he walks normally. So that these are some of the ways the patients overcome the freezing of gait without spending a lot of money. And of course, you have those gait trainers. This is one of the gait trainers. You can see the buzzing of the sound, and the green light suggests that the patient's stride length is actually good. But if it is smaller and it's not, then another sound or the red light will come out. So this helps them train to overcome when they walk normally. Okay. So this from our friends from Thailand, and Rongrush published this, I think, so many years ago. And I was so intrigued by these patients where they use this method to actually overcome their freezing of gait. Very simple method, but inexpensive method, because you just need something for them to look and to overcome that freezing. So yeah, I was very intrigued when I looked at that.
Which has been fitted with a crossbar that lies
how
across
they
the
overcome
patient's
the
back and
freezing
allows him
with
to
this.
step over it.
But of course, subsequently,
use that step.
I think they've gone so far that they have laser canes, modified laser canes. And you know, all this helps the freezing, the velocity, the stride length, and the
cane in
cadence.
his other hand.
And I just want to show this, and also I can also help to promote the Parkinsonism and related disorders Facebook and Twitter, because I'm the social media editor. But this 1 minute video will actually explain a lot on what the future is on the vibratory plantar pressure stimulation.
My name is Raja Mehana, and today I'm lucky to have Dr. Phanpathan and Dr. Bidaya Siri, who are the authors of the article Vibratory and Plantar Pressure Stimulation, Steps to Improve Freezing of Gait in Parkinson's Disease. Can you tell us about the impact of freezing of gait in Parkinson's disease?
One of the major contributor of falling, so obviously is impact patients' quality of life.
Can you tell us more on how this method improved freezing of gait in Parkinson's disease patient in your study?
That peripheral control of FOG really exists. Combined stimulation results in enhanced proprioceptive processing or dual action stimulation, which you see that it consists of the feedback and the feed-forward loop between the central and the peripheral nervous system. These two enhance the feedback signals, which ascend to the spinal cord here, the brainstem, the thalamus, and the sensory motor cortex, which contributes to the feed-forward mechanism. Synergistic effect between the signals from different receptors and area of stimulation, which results in improvement of FOG and gait parameters. So in PD patients, there was dysfunction of internal cue and the impairment of the sequence effect. So our sensory stimulation can represent an external cue, which can be used to improve the sequence effect as in our study.
So how soon do you see the positive effect on freezing of gait after this vibratory and plantar pressure stimulation?
5 minutes after the stimulation.
So what are the limitations of your study?
including the small sample size. Details about leg movement during FOG episodes were not captured. Our stimulation protocol was not synchronized to the gait cycle, and that our findings provided no insight into the long-term benefits of combined stimulation.
Practically, how can this be used in daily life?
To embed this type of the stimulation, both the pressure and vibration in the shoes of Parkinson's disease patients, and ultimately reduce the fall of the patients and improve their quality of life.
Yeah, that would be great because we're so limited to medication help to some degree, physical therapy, but then even then, so that is very promising. Thank you so much, Dr. Bidayasiri and Dr. Funpantum, for sharing this information for us, for joining us to explain and share your findings.
Thank you.
Thanks for having us.
You want to see the full interview is on Facebook and YouTube. Okay, are there other forms of non-dopaminergic therapies in freezing of gait? Rivastigmine, it did not reduce freezing of gait. Amantadine, inconclusive results. Methylphenidate only in patients with STN-DBS, but not in patients without STN-DBS. Droxidopa, insufficient results, and also caffeine estradiol, also insufficient results. So not very promising. And I finished the last case, very short one. So 80 years old, Parkinson's disease patient, 80 years old, and since 2017, 4 years. She's actually a Kung Fu master, independent. His son lives in UK and he only has a sister who is with him, and his sister is also quite old. She doesn't have any dementia, no psychosis at all. So problem is that I put him on a quarter dose of the levodopa benzalazide and amantadine, and this is him when he is on. You can see still there are some symptoms, bradykinesia, some fine tremor, resting tremors, and he's not too happy with his condition at this state because he wants more fluidity in his movements. He wants faster movements because he's a Kung Fu master who teaches Kung Fu. So what do? As usual, I would increase the Madopa to half tablet, and that's just increasing by a quarter tablet. He develops dyskinesia, and this dyskinesia plus postural hypotension, blood pressure dropped to 99/70, and he even had a fall. So I couldn't even increase by a quarter tablet. And what would you do in this case in an elderly gentleman who's 80 years old? Of course, we look at options of device-aided therapies, DBS, apomorphine, and LCIG. And LCIG is too expensive, so it's between apomorphine and DBS. Well, if you look at this in 2011, the criteria, he doesn't have dementia, he doesn't have psychosis. But the most important thing in him is probably he wants to be independent as a Kung Fu master. So would you do DBS? He's 80 years old. And actually, I took the chance of doing DBS on him, counseled him. And in fact, what took most of the time was to counsel the son, to convince the son that this is probably the best option he has. And we had in the same paper about telehealth as solution for specialist Parkinson's care in Southeast Asia. But in this case, it's not the telehealth with the patient, but with the son. So we have this experience because probably contributed by COVID-19 pandemic, we have actually experienced this combination of face-to-face or remote home, the resources and challenges like we have like the internet availability, slow internet. So, but she was in UK and yeah, there were some challenges, but I think all went well. Finally, he agreed for DBS for his dad, and this was the outcome. A very good, successful DBS. He was still able to go back to what he wanted, teaching Kung Fu and practicing Kung Fu himself independently. What's new about DBS for Parkinson's disease in Southeast Asia? Just very briefly, there are two things. One is the adaptive deep brain stimulation, which is a closed loop model where we used to just stimulate the STN or the GPI, but now you can actually have a feedback and we look at things like the pathological beta bands. And from that, it actually shows the signal, and then we adapt and try to the battery adjust it and then stimulate it at a certain parameters that would help the patient, whether in terms of bradykinesia, rigidity, or tremor. So it would improve the therapeutic efficacy and fewer side effects with longer battery life. The other one is what we call as directional leads, where the leads, if sometimes your lead is not at a very accurate position, you tend to stimulate other structures around it, such as the internal capsule, and you get capsular effect and so on. So what this does is that you can actually steer the current to one side, like in B and C, you see here. So that would reduce the side effects. Then the last one I would like to say is the genetic variants of Parkinson's disease in Southeast Asia. Our genetics may not be the same as genetics elsewhere, like in the US, Europe. So things like LRRK2 2019, which is common in Ashkenazi Jews, is very rare in our population here, whereas the 2385 LRRK2 is much more common here. So we have, and how does this genetic variance nowadays that we try to test help us in our management of our patients? We find that there are some we can actually tell. For example, the LRRK2 R1441 have a poor response of DBS outcome. And also the GBA, it doesn't last long, perhaps after the stimulation resistance response 2 to 7 years after the surgery. So perhaps in the future, probably certain genotypes will not be considered not suitable for DBS. We'll see how it comes later on. And we need to know the psychosocial factors in Asia and Southeast Asia. So there are still major gaps in knowledge, confusing Parkinson's disease with aging, poor recognition of non-motor symptoms, beliefs that alternative treatments can cure Parkinson's disease. And there are certain countries who still do not have community support groups, and certain visible movements, ruling, communication, and mental difficulties is still considered a stigma in our region here. So the take-home message, managing advanced Parkinson's disease in Southeast Asia remains a challenge. And we have actually discussed about motor fluctuations, dyskinesia, orthostatic hypotension, falls, psychosis, and dementia. And there are major gaps in knowledge in Parkinson's disease in Southeast Asia, and there are still limitations in resources and availability, whether it's medication or device-aided therapies. Genetic variability in Southeast Asia plays a role in determining treatment choice and outcome, and combined efforts and synergy among neurologists in Southeast Asia will probably bring treatment of advanced PD to greater heights. So with that, thank you very much.